Yes, thank you very much, Dr. Sanaa, for the very kind invitation for this, like to attend this and share in this prestigious meeting. And I'm really honored and happy to talk to you about anaphylaxis and drug allergy in 20 minutes, hopefully. All right. Let me proceed forward. I will start first with like 2 cases, and then I will discuss them at the end. All of us have seen like a 7-month-old infant presenting with history of profuse and repetitive vomiting 5 to 6 hours after ingestion of cow's milk without any other symptoms. In making a diagnosis, what are you going to do? Do serum IgE or IgG, or do a skin prick test in an allergy place, allergy office at Ain Shams University, more than welcome, or no diagnostic test. The other case scenario will be the same 7-month-old infant with history of repetitive profuse vomiting associated with itching and rash 15 minutes after ingesting cow's milk. Are you going to do IgE, IgG, skin test, or no diagnostic test? I don't want to exhaust the resources, and I don't want to not to do anything for patients. But let's talk about anaphylaxis. What is the meaning of anaphylaxis? Anaphylaxis means against or nothing. Phylaxis means protection. So meaning the patient has no protection. Severe, life-threatening, rapidly evolving reaction. It's a hypersensitivity reaction, meaning involvement of the immune system. It is characterized by bronchoconstriction, vasodilatation, hypovolemia, ending up in shock and death. What is the rate of like how many anaphylaxis cases are you going to see? Based on statistics and studies in New York City, the anaphylaxis was responsible for 0.18, means 0.2% of emergency department visits, 1 every 200 patients. How many fatalities? Yearly, 150 to 200 cases die in USA from anaphylaxis every year. How about the epidemiology, generally speaking, over 5 years? That was 2012, with what we call like no proper statistics because it's a retrograde diagnosis. 2,000 anaphylaxis cases were admitted to the ICU out of 600,000, a mortality of 1%. It's really serious issue, and we've started seeing this lately in Egypt because everything we see, the whole world is attached together with the fine string. Causative agents were mainly food and the blood products. Blood products, monoclonal therapy that is increasing, chemotherapies, it's a lot going there. If we look at their statistics, you will see the peanut allergy in the beginning, then followed by tree nuts and the drugs. So those are the major 3 causes of anaphylaxis, then followed by milk, fish, and other causes, and there are unknown causes of anaphylaxis. If you look at the whole world here, what are the foods responsible for anaphylaxis? What do we have in Egypt or even Africa? Still, we are the Black continent, unfortunately, regarding the statistics. And I encourage all the attendees, please do the statistics, do the allergy statistics, and it will be published in no time because we are all eager to know what is going on in the 4 continents. As I said, the hypersensitivity reactions, meaning involvement of allergy cells. Our major cell, I call it the chemical weapon cell. The chemical weapon cell is the mast cell. It is a bubbling, burning cell full of chemicals with immediate release of some chemicals like histamine, tryptase, and heparin. After a few minutes, you will find the prostaglandins and leukotrienes, and after hours, cytokines. That leads to inflammation. We've been lately hearing that cytokine storm and cytokines even are involved in anaphylaxis. All those will lead to smooth muscle contraction, edema, all the symptoms of allergies, like simply allergies. But is it enough to diagnose allergy versus anaphylaxis? We have diagnostic criteria that can differentiate between simple allergy versus anaphylaxis. Those are the systems involved in allergies, and those are the chemicals that are involved in the reactions in different organs. Histamine is by far the most important, cysteine, leukotrienes, as well as platelet activating factor. But look at the bottom of the picture, cytokines are involved everywhere, and that can explain why that symptomatology is different. Have you seen atypical cases of anaphylaxis? I've seen so many of them. For example, patients presenting with chills and fever, chemotherapy, especially in chemotherapy. If you have a consult after a chemotherapy for a child having reactions, please consider anaphylaxis. Is pain a sign of anaphylaxis? Yes. Monoclonal therapies with no evidence of IgE. Are you going to, I said like a while ago that it's a hypersensitivity reaction, but is it all related to IgE? Unfortunately, no. Lately, we have a new receptor found on the mast cell that is activated by quinolones, ciprofloxacin, levofloxacin. I had a patient who had floxacin and immediately felt weird with no typical symptoms of anaphylaxis. General anesthetics. Radiocontrast media, by the way, it's a form of anaphylaxis without the typical symptoms of anaphylaxis. Icatibant or bradykinin receptor antagonist, those stimulate the mast cell that I told you about, the burning cell that release the chemicals without the cross-linking of the IgE on it. So relatively recently, in the last few years, anaphylaxis phenotypically is divided, phenotypically and endotypically is divided into IgE mediated, that means involvement of mast cell and basophils. Let me remind you of our allergy field. Mast cell is a bone marrow cell, but you cannot find it in the CBC because once it's delivered from the bone marrow, it will go rest under the mucous membranes, the skin, the eye, the conjunctiva, everywhere. Basophil is a blood cell. So both chemicals, they have chemicals, but there are differences between both. Both of them, they carry those chemical weapons. There is a non-IgE mediated that involves IgG. We used to say IgG is not involved. No, it is involved actually in the new stimulation of the mast cells. Complement, bradykinin, leukotrienes, and different cells, also not the IgE mediated cells, neutrophils, like eosinophils, endothelial cells, smooth cells. Anaphylaxis is a systemic reaction. The triggers of non-IgE anaphylaxis are mainly drugs, maybe oversulfated heparin, so we'll find it, radiocontrast, aspirin, other antibiotics than levofloxacin, vancomycin, opiates, and general anesthetics, neuromuscular blocking agents, even physical factors that we used to say idiopathic anaphylaxis. Yes, it is there. It might not be IgE mediated, and you will find all this in this article. This lecture, by the way, will be available for everybody. I gave it to the organizers. The pathways of anaphylaxis, like anything we say, the pathophysiology, phenotypes and endotypes, that means allergy reactions or cytokines or mixed endotypes, the different cells involved and different chemicals involved, and it can be a mixed reaction. Diagnosis of anaphylaxis, I will never like stress on a fact more, even in drug history, more than history. Clinically, as I said, the two criteria for the Academy of the American College and the American Academy of Allergy, Asthma, and Immunology, as well as the World Allergy Organization. One of the following three criteria. The major one, I looked at this one, decrease the blood pressure, a patient in shock. Think of anaphylaxis. Other than that, either, this is the first one, acute onset of illness with involvement of skin and either respiratory or GI or blood. Or two systems right from the beginning, skin plus respiratory system, and here, as I said, GI symptoms. So it's either like the three major organs, the lung, the heart, and the brain, as well as the GI. The amended criteria for the diagnosis of the World Allergy Organization, they made it simple, of two criteria. What is the first one? You have a skin involvement, with hives, itching, etc., or both, plus involvement of either the respiratory system or the reduced blood pressure and end organ dysfunction or severe GI. They made it very simple. What is the other option? Acute onset of collapse, hypotension, bronchospasm, laryngeal involvement. Not all the cases of anaphylaxis, by the way, are associated with itching. Itching is present in our skin in 80 to 90%. Respiratory, about 70%. As I said, those are the most common two. Cardiovascular, less. GI, less. Neurologic symptoms are less. Cutaneous and respiratory are the most common. What is common, but you don't have to forget. Have you seen anaphylaxis in young children or infants or toddlers? Yes. You can find it, and this has been recently published. Tongue thrusting, tongue pulling, lip licking, licking of the hands, ear pulling, putting fingers in the ears, eye rubbing, shortness of breath, tachycardia, hypotension, hypotonia, incontinence, persistent GI symptoms. Those can be symptoms of anaphylaxis. You're going to tell me, is everybody then anaphylaxis? I said, no, you have to work your mind first and see the differential diagnosis. Acute allergic reactions are simple, but when I told you the diagnostic criteria of involvement of two organs, that is more important than simply looking at one organ. Acute asthma attack alone in adults, MI or PE or seizure or stroke, food allergy syndrome, monosodium glutamate or sulfites, vocal cord dysfunction, even child abuse, shock, hypovolemic shock, end organ increased histamine, mastocytosis, or mast cell activation. And this is, we are getting aware of mast cell activation from the tryptase that I will tell you, you have to do it twice for your patients with suspected anaphylaxis. There are so many differential diagnoses. When I say that it's important, don't forget the differential diagnosis. The diagnosis of anaphylaxis, if I tell you tryptase, that should be done not beyond 6 hours, maximum within 2 hours. Is it true? No. As an allergist, I will say no, because food-related anaphylaxis, you might not find high tryptase. Drugs, yes, you might find it. Insects, yes, venoms, and we are having now a lot of insects, and there are so many, as I said, even the sun exposure, physical forms, or idiopathic anaphylaxis. We don't have a lot, actually, of labs, but let me tell you this. Are you going to do the labs and wait for it and then treat the patient? No, it's a diagnosis based on clinical suggestions. Direct skin testing or serum IgE based on patient history. And reminding you, not a screening test. And this morning when they discussed the milk allergy in a very good lecture, I hope that everybody had attended, he actually stressed upon this fact. You don't do simply IgE testing, because IgE testing means positive sensitization. It's not correlated with the clinical reactivity unless you get a positive history. So it's not always clinically significant and must correlate with history and testing. But what is important, you have to treat. Unfortunately, this was the situation in USA when I first came. They used to tell the mother to get the epinephrine vial and then withdraw. But tell me a mother panicking with a child on the floor and you withdraw 0.3 ml and you give it to a patient. And sometimes even we have movies in Egypt that they broke this epinephrine vial. Egypt is in utmost need for the injectable epinephrine, which saves lives. And this is the future for 2030 or 2050. We might in ICU consider IV infusion or even intraosseous. Second line, Dr. Rasha Hassan in Ain Shams University had really very good simulation, and she is the master of anaphylaxis at our university for how to put the patient on the floor, remove the triggers, put the patient in a supine position, make sure that the airway is fine, make sure that the IV line, there should be exactly, you are doing PALS or basic life support. Somebody will put IV line, somebody will take care of the airway, somebody will give the inhalers, and the first thing is to give epinephrine. Third line, to give antihistamines and corticosteroids. Unfortunately, when a patient presents, even here, they start giving antihistamines and corticosteroids. So why do we give epinephrine? Do you remember your pharmacology classes? The alpha-1 adrenergic effect, it increases the vasoconstriction, peripheral resistance, decreases mucosal edema, make the patient breathe well, and the beta-1 adrenergic agonist, it increases the cardiac output, the beta-2 adrenergic agonist, bronchodilation, and decrease mediator release from the mast cells and basophil. It stabilizes the mast cell, which is the most important function of the epinephrine. Epinephrine is the first line. Antihistamines come second. Corticosteroids, unless the patient is in shock and you give IV, solimedrol or hydrocortisone. But if you give oral or give phenadone to a patient, it has no role in the acute management. I'll tell you why. Because simply the median time for cardiac or respiratory failure based on the antigen, 5 minutes for the drugs, 15 minutes for the venom, 30 minutes for food-triggered reactions. And the median time for the maximum serum concentration for oral hydrocortisone is 1 to 2 hours. So the patient will die before your oral phenadone will work. And based on the pharmacodynamics, corticosteroids, they are unlikely to prevent the immediate death from anaphylaxis or reduce the severity. Going back to square one, epinephrine. Steroids not in the acute management, but the steroids are needed if the patient is having asthma or significant respiratory compromise. I'm not saying the steroids are not needed. You have to put everything in the right position. I'm stressing again on the effect of the epinephrine. The dosing, we all know, 0.1 milligram per kg in infants and children. You repeat every 5 minutes, give it IM over sub-Q. Why? Faster maximum plasma concentration, which the maximum plasma concentration is reached in 8 minutes in the IM, and in the sub-Q in 34 minutes. Have you had patients on beta blockers? If you have a cardiac patient or you have a patient with hemangioma, please consider glucagon, and glucagon should be part of the emergency medications in the crash cart, whether on the floors or in the emergency department, if a patient is on beta blocker not responding to epinephrine. So you're going to ask me glucagon. This is anyway by diabetes, like it's an endocrine meeting too. Glucagon, because it's an antidote to the beta blockers and the calcium channel overdose, it acts through the non-adrenergic pathway, stimulates adenylate cyclase and increases cyclic AMP, and it has a positive, accordingly, of course, a positive inotropic and chronotropic effect. Glucagon. And you have to monitor the patient after you take care of him and take care of the other predisposing factors or associated factors like asthma or biphasic reactions. Prescribe auto-injectables, and hopefully Dr. Sameh will be available in Egypt soon, the auto-injectables, and that will be the success in the field of allergy immunology all over Egypt. Provide an action plan with all the instructions, and you have to consult with an allergist. This is an example of the asthma and also anaphylaxis. All patients with anaphylaxis, they should carry this, put it in a sheet protector so that we will raise the awareness. This is for you to know what is needed in the emergency department, what are the required places. You have to be ready for anaphylaxis in the floors, and you have to have an anaphylaxis sheet in all the institutions, or whoever is hearing me, anaphylaxis. I'm raising the awareness of anaphylaxis based on Dr. Sanaa recommendations. Let's go back to case one. Case one had just one system involvement, right? But it is delayed. And in the lecture of the food protein-induced enteropathy that was presented in the milk allergy early this morning, this patient do not need anything because this is not IgE mediated. Don't waste the resources. There is no need for IgG to milk at all. But we are talking about the IgE and the skin test. This patient is actually having two system involvement, and it's right within half an hour or 2 hours. Then this is an anaphylaxis patient. Then you have to do the IgE and think right together with the skin prick test. That can explain. Take home message: the detailed history, early giving epinephrine, early measurements of the tryptase, repeated to avoid mast cell activation. Serum IgE testing for food is used to indicate sensitization, not clinical reactivity. All emergency department and hospital floors will be prepared for anaphylaxis management. In my last 5 minutes, I will discuss a little bit of drug allergy, but as I said, when in doubt, please give epinephrine. The drug allergy can be simple things. Type A, which is the overdose or side effects, patient taking Augmentin and is having diarrhea, is not that's not a drug allergy. Type B is the uncommon, like intolerance, like tinnitus with aspirin, or idiosyncratic reactions or pseudo-allergic reactions. And part of the type B is what we call HSR, hypersensitivity reactions. And the hypersensitivity reactions is further classified according to the Gell and Combe classification, IgE mediated. Why do I say this? Because if you tell me how are you going to treat like a drug allergy? I'm not going to treat except the type 1 only. That's why I have to know that is IgE mediated. All those ones, unfortunately, you avoid. So I have to get the history and the diagnosis. And am I going to be able to treat all drug allergies? Unfortunately, only penicillin, that is the one that is documented. You will know all this from the history, of course. Type 2 anaphylaxis, whether it is hemolytic anemias, neutropenia, thrombocytopenias, you're not going to give the drug. Type 3, serum sickness or joint or arthritis or high inflammatory markers, you're not going to treat it. This is avoidance. Type 4, this is very common, the morbilliform rash. Most of my patients, the pediatric patients, they take amoxicillin for throat infection. They come on the 5th or the 7th day with rash, simple rash. Most likely, those are the benign, self-limited, and most likely when you do the skin test for penicillin, they're going to be negative, and you're going to do what I'm going to tell you right now, the drug challenge. You are not going to do induced tolerance, which would before that we used to call it desensitization. Now the term has changed to induction of tolerance. The non-immediate reactions like nephritis or severe cutaneous reactions, the severe cutaneous reactions, you're not going to touch the patient, you're not going to do any skin test for the patient. This one, unfortunately, you treat only, but you're not going to do anything to them. Those risk factors that we lately in the US in the last 2 years, we have what we call antibiotic stewardship to decreasing the use of antibiotics to decrease resistance. Simply up till now, I don't know why in Egypt it's not working, and all patients, my friends, they use for ear infections and throat infections, cephalosporins, and they use a lot of antibiotics. We up till now, we use amoxicillin with great success. Is it the drug itself or the bug or the culture? But we need to raise the awareness of this issue. The properties of the drug, the dose and the route and the duration of the treatment and the repetitive exposure is the major risk factor for hypersensitivity reactions. Decrease the use of the antibiotics, please, because those are the red ones that you will end up having antibiotic allergy. There are also, remember when I told you about anaphylaxis phenotypes and endotypes? The phenotypes means immediate reactions, that is 1 to 6 hours, involvement of the mast cells and basophils and all those cytokines that are coming from our crazy mast cell, or delayed onset, that is involvement of the T cell, and there is some genetic susceptibility. The endotypes are either IgE or non-IgE, HLA restricted. Are there biomarkers? We can do skin test only for penicillin. Serum IgE, not that much informative. Mediators during the acute reaction, we don't measure cytokines. Do we do patch test? Yes, but it's not standardized. Do we do delayed reactions? When you do the skin test, you have to bring the patient back again tomorrow to see if you have delayed reaction. The allergic drug reactions actually comprise 10 to 25% of the adverse effect, and mainly due to penicillin, amoxicillin, and Bactrim. Skin is the most important organ involved. Penicillin and cephalosporin allergy, we say that more than 90% of the patient that they say that they are having penicillin allergy can tolerate penicillin. 10% of the patients report the penicillin allergy. It's a lot here, and as I said, the whole world is becoming really one unit. Skin test negative had a predictive value of more than 95%, and the majority of the penicillin reaction are related to the beta-lactam ring. Remember, this is the pharmacology, the beta-lactam and the side chain. We say the beta-lactam is the most common one, and it becomes haptenic, and it binds to protein and started the reactions. But the reactions to penicillin can be the toxic reactions, like what I told you, the diarrhea, intolerance, abdominal pains. I don't care about it, although patients are referred to me for evaluation. But being an allergist, I have to reassure the pediatrician or the primary care that this is a safe medicine. It is a big responsibility. Or immunologically mediated. The immunologically mediated are the antibody mediated, type 1, type 2, type 3, or the cell mediated. Which one we're going to deal with? The type 1. The ones that are involved, the T cell is involvement with involvement of the eosinophils, the keratinocytes, or neutrophils that they lead to the severe skin reactions. Please Do not touch them. Severe skin reactions is like a red zone. Penicillins and cephalosporins are cousins because, again, sharing the side chain. Those are beta-lactam antibiotics. The cephalosporins, they have 2% cross-reactivity with the first generation oral cephalosporins and less than 1% for the second and the third generation. Carbapenems, meropenem, they have less than 1% cross-reactivity with penicillin. Aztreonam is the only one cross-reacting with ceftazidime, and it is safely given in penicillin allergic patients without testing because it's not related whatsoever. Is it confusing? I will make it easy for you. For example, you have a 4-year-old with urticaria and angioedema to both penicillin and Suprax, cefixime. A skin test, I've done it, and it's negative. And the patient is coming to you. Still, the primary care does not want to give the antibiotic to the patient. And instead of going to hire another class, you told him to come for an oral challenge. Then which one you're going to do, and which one that have a similar side chain? The medicine, the people, the pharmacology people made it easy. This is the group that amoxicillin that share the same R chain, the side chain with amoxicillin. Don't give it. This is with ampicillin. Those are the groups that they share with the same chain. Ceftriaxone, those they share the same. Cefoxitin, the same. Is it easy to keep this with you? No, it's not. I will tell you something better. All pharmacology department, or when we have clinical pharmacology in Egypt, they can provide this, and they come in a little sticker, like a little card that you keep it with your ID. Once you're consulted, then you can tell them the X means you cannot take it. Amoxicillin cross-react with ampicillin, cannot give it. Ceftriaxone, you cannot give cefuroxime. You cannot give cefotaxime. You cannot give cefepime. You cannot give ceftazidime, but you can give the others. That makes it easy. Is it easy that much? No, but here, children hospitals, this is from Philadelphia, I think, the Children's Hospital Philadelphia, they have even the first generation. If you need the first generation, or you need a second generation, or a third generation, or a fourth generation, the check mark means okay, the X's means not okay. So if you have an antibiotic, the patient is allergic, and you want another one, you immediately look at which one. Make it easy. No memorization. Our brains are full. Drug allergy evaluation, you do the same thing that we've done for anaphylaxis. To evaluate, as I said, you have to take good history, and you have to know exactly details of everything. For IgE1, you have to know this because this is the one that you are going to do the skin test and the positive. How to evaluate? No role for skin testing, as I said, for severe skin reactions, and those only reactions of IgE mediated. When we test, probably Dr. Samah was a pioneer in this, and we've tested for penicillin in the hospital, and I don't know whether he's continuing or not, but have to avoid the antihistamines and how to do the skin test with the various techniques that is available. If through an allergy immunology place, definitely it's easy done. Skin test is only validated for penicillin, but I heard from my friends in Egypt that it was mandatory to test for ceftriaxone. But how are you going to test for ceftriaxone? And is it informative? No. Do you have positive histamine and a negative when you do the skin test? And if you get a bleb, is it the concentration of the antibiotic that is concentrated too much? So it's an irritant. It's an irritant effect rather than an allergic effect. There is a published good one here. That's the non-irritating concentration. Non-irritating concentration, for example, for ceftriaxone, when you dilute it, look at the vial. If it comes in 100 per ml, make 1 10-fold dilution, meaning 0.9 ml saline and 0.1 of this concentration. And then you test it under the skin, 0.02 plus the saline and plus the histamine. If the patient show a reaction, what I'm going to do, I'm not going to say that he is allergic. What I'm going to do, those are the actually non-irritating concentration. Are you going to desensitize or induce tolerance, for example, to penicillin or ceftriaxone? No, because the patient do not have a history, but you are going to do a graded challenge. Graded challenge. We can desensitize. This can be done in any allergy office, allergy place. You cannot do it. There is a technique for the intravenous and there is a technique for the oral. And the desensitization induces what you need to know. Temporary tolerance in only one course. Each time you need it, you're going to do it. Desensitization has to be performed with a certified allergist. You cannot do it on your own. But the graded challenge is easy to do. Please, if you have a low-risk patient and you don't know the history, you do it 10% of the dose, wait 30 minutes, then do the rest of the dose. And we are in the now new practice guidelines in 2022, they reinforce the graded challenge. If you suspect that the patient is having ceftriaxone allergy, you give 10% of the dose, wait 30 minutes, give the rest of the dose. And completing the challenge without adverse effect to show that there is no immediate IgE related. Those are free for everybody. The practice parameter updated for drug allergy and the drug allergy 2022, it was just published September 17th, 250 pages for all the statements that you need to know about drug allergy. What is the take-home message? Hypersensitivity reactions is a small subset of adverse reactions. If allergy is suspected, careful allergy history, physical exam, the next step to help distinguish between hypersensitivity reactions, common or severe. Skin testing, challenges, test doses, and desensitization can be performed by allergists to help make the diagnosis and the treatment. And thank you very much for all your listening.
Thank you very much, Professor Sanaa. Thank you very much indeed. Your presentation was the point. Actually, when you visited Mahadi years ago, our practice has been changed.
Okay, great.
Really. And also consider epinephrine use and IM mode. With all these things, actually, it was new for me and for my colleagues at Mahadi. Thank you very much.
You're welcome.
But let me ask you a question. If we give epinephrine, you have mentioned, but I would like to make it clear, and if it is not due to drug anaphylaxis, does it make any harm? And the dose related, you mentioned, but I would like to hear it once more.
No, even in adults with myocardial infarction, epinephrine is indicated. Epinephrine saves lives. This is my even personal experience myself. Patients even with simple itching in the mouth, simple throat itching, oral allergy syndrome. This morning, they discussed the oral allergy syndrome, and I was so happy with the lecture this morning. It was really informative. If you give it early, you catch the pain, you save a life. You save a life. And here, epinephrine, they had a lot of arguments because it was expensive. And all the media was against, and the same company, they used to sell it for high. They started making generic epinephrine, and the price went down for everybody now to have it. Even patients with simple allergies, this prescribed epinephrine when they go from the hospital. It's a win-win situation, even if they don't use it. And the good thing is that the expiration date, even if it expires, the efficacy is 95% after the first year of expiration. So you can use an expired epinephrine with the same almost efficacy. So it's not a waste of money. You are a leader, Dr. Samah. We need epinephrine in Egypt. Epinephrine, now we are having monoclonal therapies, we're having chemotherapy everywhere, and you have a lot of reactions that are not diagnosed. Anaphylaxis is underdiagnosed in Egypt. We don't have even proper statistics.
Yes. Okay.
Half a minute, please.
Is there any?
Half a minute. Could you allow me half a minute?
Okay, go ahead, Nick.
Okay. Thank you very much, Professor Sanaa. Really, I met you a lot in Adjunct University and also with Professor Samah conference. Thank you very much for this panoramic presentation and very important regarding the anaphylaxis.
You're welcome.
We are facing now a lot of cases of anaphylaxis in the ER and the critical care, and you simplified the management, which is so simple, but it's applied. Thank you very much.
You're welcome, sir. My pleasure. Thank you.
Next speaker, Professor Sanaa.